remember new information, objects, and events in our lives. But the thing that tends to affect most people is their ability to remember incidental memory, which are procedures, how to do things, like how we wash our hair, how we brush our teeth. And that's something that isn't always assessed in a typical neuropsychological evaluation, but once we include the adaptive behavior pieces, then we get to look at that as well. The next category is visual spatial functioning. And again, we want to know, do you learn better when you are, well, can you process information better when it's visual versus when it's auditory? So after the visual spatial functioning, and you could put that one up too, we have two more categories. The next one is executive functioning. And executive functioning is how behavior is expressed, how or whether a person can do something, and what or how much weakness a person may have, for example, in areas like self-care. This also includes attention. Can you focus your attention? Can you have selective attention when there are distractions in the background? When you are trying to complete a task, can you sustain your attention? Can you alternate attention between a conversation with someone and a puzzle you're trying to complete? So we look at all these things and the factors that can affect them, like fatigue, medication, or environment. And then the last category on this page is mood and personality. And we certainly want to look at mood and personality because some aspects of mood disorders can actually impact our memory and our learning. It can also affect how we can interact with people and how we're able to communicate with others. So we want to be able to look at everything all at once and be as comprehensive as possible when we're giving you an assessment. On the next slide, we look at, I've included a picture of a bell curve. I don't know if some people are familiar with this. The reason I wanted to share this with you is because quite often people get their neuropsych test results, and what they see is, I'm in the 65th percentile, and they compare it to what their learning is when they were in school, and a 65 is never passing. However, on the bell curve, the average range ranges from 25th to 74th percentile. So anything within the 25th to 74th percentile is average. And the reason we use this bell curve is because we're looking for relative differences. We want to be able to use our data to estimate premorbid abilities and whether or not we have relative changes or significant changes. So when we tell someone, yes, most of your testing is average, but some things are in the low average range, that's a relative weakness. That doesn't necessarily mean that we have a cognitive impairment. Something that's lower is going to be something that's more significant and something that we certainly do want to address. Okay, if you can go to the next slide, what I think we should start talking about first before we talk about dementia care is also typical aging. Traditionally, we do have a decline in some aspects of our daily cognitive functioning as we get older, and we see the decline in information processing and speed, and executive functioning as we age. So when we do our testing, we're not comparing the same norms for a 20-year-old as we are going to use for a 60-year-old, 70 or 80-year-old. Typically, most of the tests have validity for 5 to 10-year age increments so that we can be as specific as possible as to what's appropriate for age and, when possible, also for education. So we want to be able to create a neuropsychological profile of what's typical for each individual in terms of their own aging. But slowed speed seems to be one of the most predominant ones. Also, another thing we want to take into account is how active someone is in the community. What kind of work do they do? What kind of interest do they have? Because all of these things are going to be very sensitive and something that the testing will pick up on. Okay. On the next slide, I have some information about the MCI diagnosis. The mild cognitive impairment diagnosis is something that many people are using with more frequency now. And what we want to find in that client to give them this label is whether or not there's evidence of concern regarding cognitive changes. Sometimes people come in and they don't have that insight to know that there's a change, but other people are documenting it, whether it be within medical records or just family members. In order to meet the criteria for this diagnosis, you need to have a documented impairment and at least one cognitive domain. And those cognitive domains, just to go back to that, include the executive functioning, the learning and memory, the language, all of those. Okay. We also want to look how we can preserve daily independence. and complex functional tasks, because we want you to be able to continue to pay your bills and prepare meals and shopping, and those things are often the first hallmark that there's something happening. Changes are usually determined within an individual. It's not, there's no metric that says when someone is having trouble paying their bills 3 times in 1 month, then we have a problem. But rather it's whether or not there's a relative change for that person. If that person has been paying their bills all along and all of a sudden now we see that they're having trouble just getting to the supermarket and accomplishing tasks, then we certainly want to address that. The most common symptom in clients who are developing an Alzheimer's dementia typically include complaints of episodic memory. Okay, Heather, I'm having trouble with my screen, so if you can go to the next screen. I can't see, I'm hoping to get that up so I can see that. So on my next page, I want to talk a little bit about diagnosing dementia. When we talk about how to diagnose a dementia, a lot of this has to do with, unfortunately, where you live and what doctors you have access to. In the last 40 years, people have tried to centralize the way in which we diagnose dementias. In 1983, they came out with their first parameters for what a dementia should, what the diagnostic process should look like for individuals. And that first ruling or paper that came out on it was written by the National Institute of Neurological and Communicative Disorders and Stroke, along with the Alzheimer's Disease and Related Disorders Association. In 2011, they decided to update these diagnostic criteria because they found that people were not always having access to all the doctors that were on the list. The most critical thing in making this diagnosis is that they wanted people to be able to, again, document a change and to rule out that there were any other conditions that could be causing the symptoms that were being reported. So we're looking for cognitive and behavioral impairments in at least 2 cognitive domains, and that's one of the hallmark differences between this and a mild cognitive disorder. We also wanted that this is something that can be diagnosed and detected not just by the family, but something that could be diagnosed by actual treatment and metrics, by doctors, and it could be from neuropsychological tests or observation. Okay, on the next slide, I have common types of dementias. Common types of dementias include several, and you can pull all of them up. The first and most prominent that we talk about are Alzheimer's disease, and one of the reasons why we're here today talking about it. Also, vascular dementia, frontotemporal dementias, and dementia with Lewy body. One of the things that neuropsych testing is very valuable in is actually breaking down some of the differences between them, because each of them present with different cognitive symptoms. And that becomes very important because the treatment process is very different for each one of these. Okay, so just to give you some examples. In Alzheimer's disease, Heather, are we on? Can we move forward on the slide? Great. Oh, no, I'm sorry. Common types. I just want, my screen didn't have that yet. Do you mind going back to the common types? Thank you. Okay, I'm sorry. I just got my screen back. Okay, so on the Alzheimer's disease, we know that there are various models that look at the different stages of the disease so that we can look at the gradual progression and how to help people at various stages of the disease. With vascular dementias, we often see that there is an onset of strokes or a series of strokes, and then we have almost a stepped progression. So rather than a gradual progression through the impairments, we're seeing that things are very pronounced, and it looks like you're walking down a flight of stairs. Often there's a preservation of emotion and personality, very dependent on where the incident is of that stroke on the brain. Frontotemporal dementias, the area of the brain affected is usually the area, the frontal lobes, where we have behavior, emotional regulation, and language. So memory abilities often stay intact longer than some of these other symptoms. And finally, the dementia with Lewy bodies. Here we have microscopic deposits that cause degeneration of nerve cells in the brain, and we often see symptoms of Parkinson's disease in majority of these patients. And in this case, unlike the other dementias, we do have more fluctuations on a day-to-day basis. So the care for each of these conditions is very different, often requires different types of medication, and we want to make sure that we're getting it right. On the next slide, dementia versus depression, one of the reasons why I wanted to also call your attention to this is that on MRI research, we find that late onset depression is consistent with enlargement of parts of the brain that we often see affected also by a dementia. So with someone who has depression, on clinical interview, we often find that they have more complaints about memory problems than someone who has early stage dementia or is progressing through the stages of dementia. So what we want to do is we want to use all this evidence to figure out, again, are we giving this patient the appropriate treatment? And how do we determine what's happening? So cognitively, speech is typically intact. There's awareness. Sometimes it's almost a hyper-awareness of the symptoms of the depression. And we do see a very strong relationship between severe depression and memory impairment. So we do want to rule that out, so not just for the treatment, not just for the diagnosis, but also for the long-term planning. And some of these things don't exist in a vacuum. We do have that overlap of two situations at the same time. With the dementia, we typically have, and this is how we make that rule out, the reported onset is gradual over several years, where the person with dementia will have a more rapid complaint of onset and less likely to have some of the more apathetic symptoms of a depression than someone who is depressed, where the memory impairments are more significant, again, with less insight. Okay, and on the next slide, what I did is I gave you an international attitudes towards care, a summary of a research study done in 2004. According to a lot of the research that's out there, different countries are addressing dementias in different ways. And so what they did is they took a look at how several countries, and they didn't include us in this study, and that's fine, but it'd be interesting to see how quickly we diagnose dementias here. From the time in which someone complained of a memory impairment to when they were actually diagnosed with a dementia. That's our first row. Then it became, okay, what's happening in terms of people considering treatment for that dementia? Because in some cases, and you could see in the UK it was less likely to happen, people weren't really proactive. The doctors weren't proactive in coming up with a treatment plan or prescribing a medication. Some countries were more sensitive than others. And at our final row is their belief that medication can actually make a difference in the prognosis. And I'm sure everyone's heard that without getting into any of the psychopharmacological treatment plans or studies, that the medications some people believe have not had the impact that we want them to have. So I think that might be informing some of the drive from the UK doctors, but we have this hesitancy to address and treat in many countries. And what they've discovered in researching independently what's happening in the US is that we have more and more people who are moving into living care facilities. And about 50% of those that are moving into them, and this was research done in 2007, 50% of those moving into assisted livings and nursing homes have been told that they have some stage of dementia, whether it be a mild cognitive impairment or they're suspected that they're going to have a dementia. And so now we have services that are needed for these people, the proper doctors to treat it, and not everyone is following the research in the same way. And that same reluctance to diagnose that you see in the UK compared to, let's say, Germany, where they're responding so much more quickly, seems to be something that everyone's encountering at some extent during their loved one's care. Okay, so on the next slide is a little more information about the United States statistics that we know about. And this is from research done also in 2007. They're anticipating that by 2050, we will have a significant increase in the number of older adults that will require care. For example, they're saying that adults aged 15 to 64 then will increase by 24% compared to 2007, whereas adults over 65 will increase by 130%, and adults over 80 will increase by 189. So this lack of diagnosis or lack of a treatment plan is not something that's exclusive to us, but something that is an international dilemma that we have to address. And the government funding that many people are feeling are their only options don't emphasize the option of staying in your home and having care coming to you, but rather of going to an assisted living facility or a nursing home and having that care. Okay, if you can go to the next slide. So the question is, what do we do about all this? So there are a couple of things that I want to talk about in terms of cognitive interventions. So just to define our three terms, what are they? The first one is cognitive stimulation, and that is engaging individuals to enhance their general cognitive and social functioning. The second one is cognitive training, teaching strategies and skills to optimize functioning. And the third one is rehabilitation, and by far the broadest of any of these terms. It's an intervention that allows you to actually tackle and address the cognitive deficits that are really plaguing this individual. So I know they all sound a little bit alike, but stimulation is something that we can do in our own homes and doesn't really require us to engage in medical treatment, or you don't need a doctor to help you with that. It helps sometimes to get some guidance from a neuropsychologist or a cognitive therapist, but it's something that you can do as simply as saying, I'm going to watch television, I'm going to watch my favorite show on TV tonight, and then I'm going to turn around and discuss it with somebody. That's cognitive stimulation, because you're engaging the brain in a different way, and you're also increasing that social piece. And one of the reasons why that becomes valuable, even though that doesn't sound like a very challenging task, is that when you're having a conversation with another person, there is more pressure on speech. You need to be able to respond to the other person in a timely fashion. You have to understand what they're asking for, and it becomes, from a neuropsych standpoint, quite complicated. Okay, and then training, that would be working with someone who can help you optimize those functions. Okay, so on the next slide, I'd like to answer the question, why do we even want cognitive interventions? All of the research that we typically release to people is supportive, and it's also talking about medication options. But to take it one step further, one of the things that we do talk about and that we know about from a neurological standpoint is that there is a certain amount of neuronal plasticity. Our plasticity and our ability to adapt to damaged different parts of the neurological system is more pronounced when we're young. However, we are very good at compensating for things. You know, when we have to compensate for a difficulty walking, we use a cane. Our body can actually allow us to compensate and adapt a certain degree of stressors just within the body. And we want to actually tap that. The other reason for a cognitive intervention is cognitive reserve. There is evidence from specific cognitive training programs that we can actually lessen some of the risk of cognitive decline among healthy older adults just by giving them more of these challenges and more of the stimulation and the training and the rehabilitation skills. We do know for a fact that having a higher education, having a challenging cognitive job, something that is mentally demanding, and someone having a lifetime of stimulating pursuits and interests are all believed to have a protective effect and protect that cognitive reserve. That's why we talk about the bell curve. Everything on that is relative. We're comparing where you were, which we could figure out through the neuropsych testing, with where you should be now. And we believe that a lot of these cognitive interventions can actually help to delay onset or temporarily help you maintain where you are. So that's why we want to emphasize those aspects of cognitive reserve and overlap them with the neuronal plasticity. The third item on the list is physical exercise. And a lot of people don't expect neuropsychologists to talk about that, but there is a very positive effect on cognition when you're getting regular physical exercise. It doesn't mean you have to train for anything or you have to stay in that yoga class or really consistent step aerobics or karate or anything like that. That consistent walking, that consistent exercise has a tremendous effect. And we're looking at really moderate levels of exercise that have really improved people's cognitive functioning. Okay, on the next slide, I want to give you some examples of some of the strategies. So this first page is going to talk about compensatory strategies, and after this we'll go into some of the restorative strategies. Basically, when we're trying to learn something new, or we're trying to learn information from a conversation, what we're trying to do is input it into our brain. That process is called encoding. You'll hear people use mnemonics for encoding. You'll hear people even talk about association. There are a number of strategies that we use to just try to strengthen someone's ability to even input the information in their brain. If you are easily distracted, or you're not feeling well, or there's a really loud noise and that distracts you, or you're thinking about food, we've already limited your chances of learning a new piece of information. Visual imagery is certainly one of the techniques that we use to try and help people make connections. Not everyone can do things using visual imagery. Some people are auditory learners, and that's why we want to be specific in how people learn so that we can help you to maintain and build on your skill set. The next one, external memory aids. The example I give most of my clients who are really resistant to using a daily planner or using the calendar in their phone is that we wouldn't let you fall down and make you skip using a cane or a walker if you needed it. So this is kind of like the cane or the walker that's going to help you get through the day and help you get through the day effectively. Because there's no point in just surviving the day. We want to help your day be productive and have you have that emotional contentment and satisfaction with how you got through the day. And then the didactic approach. There are a number of tasks and exercises that we use to kind of break these down and help people to find those other options. You know, people use their pill organizers so that they don't have to remember to go into every bottle. Things like that that we try to overlap and help them be more effective. And that's where we want to take whatever skills are working and we want to generalize them to other aspects that people are struggling with. And then we also want to give people an opportunity to apply them in, well, that would be generalizing, applying them in other areas, but then build on them. And that kind of leads us into the next slide, which is restorative strategies. So in restorative strategies, these are the techniques that we use to sort of help someone to expand the basis of what they're doing. What the goal is of restorative strategies and in using any of these therapies is if we can help someone who's coming in and saying, yes, I have no problem getting through the morning routine, but then I can't get to the next step. We want to use some of these techniques and strategies to help you get there. We want to keep adding on to what works without overwhelming anyone and gradually withdraw the input and the support so that we're making the day run easier. We're helping that person to stay as independent as possible, as long as possible. And then obviously have that supportive distant supervision when necessary. And as that person needs more, we have someone there who can see, okay, vanishing cues technique, I'm going to keep cueing you and you can do it by yourself. Now you're doing it by yourself. I can exit the scene, but now from a distance, I can see when you need me again and when I need to make a change in how much support you need with other aspects of the day. Okay, and you can head to the next slide. So the way we do this type of treatment is that you can work one-on-one with individuals, with a doctor directly, or there are even group options available. There are a number of programs that it's sometimes easier to work with other people who are experiencing the same thing. And there are places that do that all over the country. What should be done in coming up with a treatment plan is utilizing the neuropsychological data that is available. And if it's not available, we can also work around that. Most people get the neuropsychological evaluations, and a number of clients have said this to me, and in some support groups I've been to, they've said, I now know my loved one's IQ, so what? It's not really very helpful to coming up with a treatment plan. As you've noticed, I haven't got into the psychopharmacological treatments of this condition. I'm not looking to make changes or tell people not to take prescribed medication or to take it. What I think we can do to try to make people's lives a little bit easier is use this data that we get from the neuropsych testing. Are you a better learner when it's auditory or visual? Are you better off when someone's demonstrating? Use that information to come up with a treatment plan so we know what compensatory and restorative strategies that we can use to help maintain where you are. And this is the type of practice that we should be offering clients who are concerned about dementia care. Okay, the next slide. So some of the resources in the community are, of course, going to be some of the the Alzheimer's Foundation of America, who could provide you with information, not just webinars, but also direction. And I'm sure all of you are aware of their program. There are also memory centers that have started to pop up in many different communities because there's this growing need for it. Neuropsychologists, as I mentioned, tell them you need more than the testing. If they don't do it, find out who they can refer you to who can. And then the fourth one, and this is the one that I think is also very valuable and something overlooked, are neurorehabilitation facilities. In the neurorehab setting, all of us focus on how do we restore someone's ability? How do we get them back to where they were before their head injury, their stroke, their accident of any kind? All of those strategies are critical to what we're talking about with this population. In dementia care, we want to help people to be more independent in the home, which is the same thing that our goals are in the neurorehabilitation field. So we have that very significant overlap between them. And it's a resource that's often untapped by clients who are in the dementia field because they're just not aware of it. So I don't have any other slides for you guys, and I'm happy to answer any questions.
Okay, thank you, Dr. Sophia. Now the line is open for questions. And once again, to ask a question, again, we are still in listen-only mode. On the right-hand side, you'll see a box that says questions. Simply type them in. I'll read them, and Dr. Sophia will answer. One of the first questions we have is, are neuropsychologists covered by insurance? And if so,
absolutely. Sorry.
Okay. No, and if so, what type of insurance accepts, or what type of insurance can be utilized?
All of your typical insurances are accepted by neuropsychologists. One of the things that sometimes makes it a little tricky with insurance is that there are a lot of neuropsychologists in private practice who will not accept insurance at all. However, there are neuropsychology departments in most hospitals, and they accept whatever insurances are accepted at those hospitals.
Okay, thank you. Another question that we have from Megan, and I apologize, the first question was from Susan. Megan asked, what are good professional networks for neuropsychologists?
For finding one?
I'm not sure if she meant for finding one or just for professionals.
There are a number of resources that are available to neuropsychologists just for communicating with each other. And, you know, from that standpoint, there are a number of places where neuropsychologists communicate about cases and do peer reviews and collaborate. In terms of finding one, there are a number of insurance companies that now do actually list neuropsychology as its own field, and they don't group them in with the psychologist. When you search online for them, you can find them in a lot of ways, but we also have board certification process in which you can search for neuropsychologists in your own state and in your own city. There are over 1,000 neuropsychologists that are board certified just in the US and Canada.
Thank you. Another question that we have is, how do you handle if their primary GP won't give a referral or dismiss family's request for neuropsychologist involvement?
Well, one of the nice things about being in neuropsychology is that we don't always need the GP's involvement in order to do an assessment. Just like anyone can call a psychologist and say, I think I'm having issues that I need to come in and discuss with you, same thing with neuropsychology. There are a few cases in which insurance companies require the referral, but it's not always. And there are ways that we can also help you to navigate that piece if you're concerned and you just want to make that appointment and just have that consultation.
Thank you. I'm sorry, I'm trying to get... Another question is, are there any free training programs you recommend for neuropsychologists wanting to work in dementia clinical trials?
Yes. There aren't any formal courses that I would recommend. There are a number of centers that provide dementia care or do dementia research that are consistently looking for neuropsychologists and do offer some trainings and educations throughout the year. And what I would do is I would check your local hospitals and see where your local Alzheimer's research centers are and contact them.
Thank you. Another question that we have, is it true that a dementia diagnosis may make it impossible to get insurance?
I have heard that in some cases people have struggled with things like life insurance after they've had the diagnosis. In terms of health insurance, I haven't heard that issue because I know some people treat it as a pre-existing, but that's not really my field of expertise, so I can't speak to that too much.
Thank you, doctor. Another question is, can you explain the term myocognitive? My apology. Can you explain the term myocognitive?
A mild cognitive impairment, and that's something I touched on briefly before, is something that is a condition that is usually not meeting the criteria of a full dementia. And that's where that diagnosis was initially born, with trying to address people's decline that didn't really fit into a different window, and something other than was just a cognitive disorder not otherwise specified. So a mild cognitive impairment, that diagnosis really requires not only concern about cognitive changes, but documented impairment, typically with at least one incident of testing documenting that there's one cognitive domain or more that has been changed, that we see that significant, or not even significant, but it's not a relative decline. There still may be preservation of independence in the community and within the home. And again, any changes that person is experiencing is not comparative to other people, but just comparing that person to themselves.
Okay. Another question is, I'm a volunteer caregiver who is also a special education teacher. I know a 90-year-old woman who has primary progressive aphasia and lives in a skilled nursing facility. She really can't talk, and using writing is getting increasingly difficult for her, both physically as well as writing the words she wants. It's difficult to know if she also has mild. It's difficult to know if she also has mild cognitive impairment in conjunction with aphasia. I think it's important for her to have an evaluation to find out so we will know how to treat her better. However, no one seems to be taking the initiative to get this done. Would a neuropsychiatrist be able to test someone with such severe language deficits?
So when someone has a primary progressive aphasia, the best step that we can take is set that person up with a speech therapist. And the reason I'm not saying go to the neuropsychologist as your primary contact is because our best way to help someone with that diagnosis is to get them a speech therapist who can help them come up with an alternative form of communication. Writing is, for many people, the go-to solution, but we have so many electronic and non-electronic communication devices that can help this person to really express herself and make her needs known. Because she can't express herself and make her needs known in anything other than writing, which, as you mentioned, is getting more difficult, we don't know if we have a primary cognitive issue or if it's primary aphasia. Unfortunately, primary progressive aphasia, that diagnosis cannot occur simultaneously with most of the dementias. So we consider that a rule out, and we wouldn't consider the dementia diagnosis or an MCI diagnosis. What we would do is we would try and treat the other conditions that are occurring simultaneously that can occur with that primary progressive aphasia, because it is an aggressive, deteriorating condition. In addition to working with that speech therapist, and this is where the neurorehabilitation piece comes in, that speech therapist who's knowledgeable about aphasia and those compensatory tools for communication would also most likely set you up with a neuropsychologist to help facilitate an evaluation so we can monitor cognitive functioning and figure out, what else we can do to make her life easier so she's not working as hard.
Thank you so much. Another thing, it says she does see a speech therapist. She refuses alternate methods. So I think that was just a comment right there. She does see a speech therapist. She refuses alternate methods. Another one is I advocate strongly for her to get an assistive device. She has it and won't use it. We made her a communication picture book, and she won't use that either. I think these are just letting you know. Another question we have is that currently my facility is using the mini mental as a basis for a dementia diagnosis and then offers medication. What are your thoughts?
Well, the mini mental status exam is, it's a very quick and easy way to make a basic diagnosis about cognitive impairment. In my practice, I don't find that it's specific enough to diagnose a dementia. Realistically, someone who is experiencing dementia or is suspected of starting, unfortunately, the dementia process, we can't give them the typical 6 to 8 hours of neuropsych testing that we would give someone else. So I use an abbreviated evaluation that I give them that I try to aim for 1 to 2 hours at most, and it's something that I can break down over several visits to make it easier, because giving someone just the diagnosis and the medication, in my opinion, isn't enough. I think we need to be doing more for people. I think we need to be offering them more options. And I know that often staffing is limited, and so they try to come up with shortcuts. I just think that, in these situations, it's great to have the family advocate for an assessment either in the facility or outside of the facility, just to clarify the diagnosis. The mini mental status doesn't tell us what type of dementia that we suspect someone has, and I think that makes a really big difference in how we want to help them.
Thank you. We have another question. Could you elaborate a little more regarding late onset depression and its relationship to dementia?
Sure. Late onset depression often includes sort of an increased awareness of some of the cognitive symptoms that people are experiencing. So sometimes we get someone coming in with all the complaints that sound like they are the perfect candidate for a dementia care program, but that's not the true diagnosis. One of the reasons why I wouldn't rule out testing with someone with who's complaining of this but is suspected of having a depression is because sometimes and I've seen this go both ways. A number of years ago, they were going to do a rather intensive treatment for a client who they thought had an extreme case of depression, and he was in the early stages of a dementia. And the treatment they were planning would have had pretty profound effects in setting him backwards in his treatment. So the problem goes both ways. But late onset depression, we often find, has a number of what we call the more vegetative states than a dementia typically does. And what I mean by the vegetative states is we're talking about more of the apathy, not the restlessness, but rather just the withdrawal from things, the sleeping all day. Those are the symptoms that we often see that overlap. I hope that answered the question.
We do have another question. This question is dementia reversible?
At this time, we don't see that any of the dementias are reversible. We find that there are certain things that you can do that can have a temporarily help the maintenance of someone's abilities. We don't have a medication that is the perfect medication to reverse what people are seeing, but the behavioral strategies that I'm talking about are not intended to reverse a condition that's a progressive medical condition. And again, I want to emphasize this is an organic thing that's happening. It's not something where you're just helping someone to make a different choice and choose to remember. So with that in mind, the strategies we're talking about are just to help the day be more effective. And sometimes these behavioral strategies will not show tremendous impacts on future neuropsych testing. They focus more on quality of life and something I referred to very briefly, adaptive behavior. And what that's looking at is just someone's ability to function within the community, within their home, and be able to do as much as possible.
Thank you. Again, we have another question. As an occupational therapist, what assessments would you recommend that would contribute to the team, increase advocacy for the clients, and benefit the caregivers?
Well, I can tell you that when I work with someone who has a diagnosis of dementia, I never see that person in just a vacuum. When it's possible to get them involved in other services, what I typically do is I make sure that I educate those other therapists and let them know this person is a visual learner. This person can handle about this much before it becomes overwhelming, and you can see them not able to handle any more information. I use the information from the neuropsych testing and the observations I make during it to help inform other members of the treatment team so that we can make all of the treatment time, in case it is limited by insurance companies, as effective as possible. In terms of working with the family, what I want to know from them, not just what are they observing with this person and seeing what needs they feel they have, but what are the critical things that would make everyone's life easier in the home? What services, what goals do they have so that we can address those? In some cases, I have people who are diagnosed with dementias who only want to go to their occupational therapist and get their clearance for driving. We need to come up with other options. And so we do have to work with, as a team, all of us, the family, the therapist, the neuropsychologist, and the client when possible.
Thank you. We have another question. Can high levels of stress mimic the signs of dementia at age 48?
I think that that sounds like a novel situation to me. I'm not aware of stress having that profound effect that, given an assessment that would diagnose the dementia, that would actually, someone would actually demonstrate dementia on that type of assessment. Stress can have profound effects on your memory and absolutely your ability to attend and function throughout the course of the day. But there is unfortunately also something, early onset dementia, which can occur in your 40s with some people. We don't anticipate that stress can have that effect. If someone came to me with the complaints of a dementia and they were in their 40s, I would certainly do the dementia batteries of testing as a rule out, because what we're most likely looking at is, again, that close connection between brain and behavior, where behavior can unintentionally, I don't want to say sabotage, but kind of get in the way of consistent cognitive functioning or the use of good strategies on a regular basis to help things just be more effective. And that's usually where we find that fallout.
Thank you. When do you recommend people when do you recommend people trying for a trial? My mom was recommended for a trial. I think they're referring to a clinical trial, when it was too late after taking Namenda for 2 years. I wish I would have known earlier that this was a possibility. So again, her question is, when do you recommend people, enrolling in a clinical trial?
Unfortunately, this isn't something I typically deal with in my practice. I usually ask people to consider take advantage of the resources that you have. There are a number of agencies, including the CDC, that actually list ongoing medical trials so that you can always review those and see if there are others that your mom does meet criteria for. Some medical doctors will actually keep track of those so they can let you know about it. But it's not something certainly that I keep track of.
Thank you.
But there are a number of resources in the community. I'm trying to think. I actually was at a conference and learned that there are other conditions. For example, a Parkinson's conference that I was just at mentioned that they have a website that keeps track of all the other disease medical trials as well, because they figure if you're coming to look for one thing, maybe there's something else that you'll be willing to volunteer for. So sometimes we do have that cross postings.
Yeah, and I know also the National Institute of Health, the NIH, has a listing of clinical trials as well. Another question that we have is, what is the new medication that is out there? What is in the pipeline from Biogen, etc.?
Well, I don't follow the specific medications, but more the science behind some of them. And some of the issues that we've had in finding the perfect medication for this disease is that people are still experimenting on what we need to target with these medications. So I just fortunately or unfortunately subjected my husband to a dinner where he got to hear all about the different proteins on the cells and what the different drugs are trying to target and which ones we're hoping to target in the future. And my husband's not in the medical field, so I think it was a little overwhelming, but we really are still trying to figure out a lot of this. There are suspected proteins that we think we can tackle, and that's why over the years we've had those tests that were supposed to help us predict whether or not someone was going to even have the plaques that would lead to a possible dementia. That research is it's still ongoing and evolving, and I'm not sure what the next new products are going to be.
Thank you. Another question that we have is that my husband was suggested to have a battery of a neuropsychological exam. I heard those were hours long. Could you go into a little detail of what my husband will be expecting?
Certainly. There are different types of neuropsychological evaluations that are performed regularly, and it's very dependent on the diagnosis you walk in with. So for example, someone who is coming in with a suspected learning disability or has a plan to return to college, their evaluation is probably going to be 3 to 4 times longer than what your husband would be looking at. Typically, the evaluation starts off with a clinical interview. Some of the neuropsychologists will actually send you some paperwork to fill out in advance, just to shorten that time period of that clinical interview. And they will most likely ask you to be present as well to give any additional history or provide your observations, which are also critical to the diagnostic process. Then the testing is something that he would do in the room with the therapist by himself. We don't have anyone out observing. We find that that makes a significant difference in how people have test performance issues. But the testing typically done in, depending on the neuropsychologist again, 2 to 3 hour windows. And as I mentioned, when it comes to someone who has a suspected dementia, I try to get it down to, 1 session, 2 at most, so it's not too overwhelming. And we take breaks. There are bathroom breaks and everything if you need it.
Thank you so much. Another question statement, if you experience decline in cognitive function, memory loss, including critical thinking, however the person is not over 62. I'm not sure what the question is here.
It might be what to do next.
Okay, maybe.
That would be my guess.
Okay,
but,
okay.
If someone is experiencing multiple changes, I would consult with the neuropsychologist about testing, because it's important to see what the whole picture is. And the reason I say that is, of course, let's do all the rule-outs first. Go to your medical doctor, have a solid checkup. Make sure all of your medications are beneficial to you, that they're not, you're not dealing with any adverse effects. I have had people who've come to me and said, I'm so sleepy during the day I can't function. I can't make a good decision. I don't remember anything. And it ended up that their medication side effects were increased sleep, and they just couldn't get through the day. We spoke to the pharmacist. We spoke to the medical doctor. We moved those morning medications to nighttime, and now this person had a day and wasn't up all night. So sometimes there are behavioral things that we don't take into consideration. I've had doctors say that they prescribe certain medications for the morning because that's just the default on the prescription computer program, not because it's something that's better necessarily for the client. So feedback to your medical doctor, I always think, is the first step. Ask about those concerns. If that doesn't get resolved by medication or by any other changes in your, I wouldn't say in your daily routine, like your next door neighbor now has a dog and you're not sleeping, or your partner's snoring and you're not getting good sleep, and so now you're having all these cognitive changes, then absolutely go to a neuropsychologist. You don't have to start with neuropsych testing. You can do something that is just that clinical interview and see if this is even a good fit for you. Call a local neuropsychologist. Ask them questions about whether or not this is something that they feel would be beneficial to you. I know there are people who I've spoken to, I've told them, go to your medical doctor first. Don't put yourself through the testing at this stage because let's rule out that it's not a response to medication. But if you find that everything else has been ruled out and the only thing left is to do that neuropsych testing, when you come in to speak with that neuropsychologist, share what your concerns are. most of them will ask you what your stamina is like. When you're experiencing these kind of changes, you may not be able to do a 2-hour neuropsych testing. You may opt to then say, I'm going to do 1 hour at a time, or I'm going to do an hour, take a break, and come back. You know, we have certain flexibility because the goal is to see you in a quiet environment and to see you at your best. But again, it doesn't necessarily mean that there's a dementing process starting.
Okay, thank you. As of now, we don't have any more questions. We do have a couple moments left. I want to take this time to just let everyone know that on November 16th from 1 to 2 p.m. Eastern Time, we have an AFA Special Edition Care Connection webinar. It's special considerations for individuals living with post-traumatic stress disorder and dementia. And that will be by Kathy Jonas and Sarah Rodriguez. So I'm welcoming everyone back on the 16th for our Special Edition Care Connection webinar. I also want to thank you, Dr. Sophia, for an amazing presentation. We have a lot of people typing in saying thank you, and the information was really informative. So I certainly learned something new today, and it sounds like the participants also learned something new today. We do actually have one more question that was snuck in, okay. For a person living in the Bronx, where would they go to find a neuropsychologist?
Okay, well, you have a number of hospitals there that actually do have neuropsychologists on staff. I actually did my graduate training up in the Bronx, so I can tell you that both Jacobi Medical Center and Albert Einstein have, and Montefiore, all have neuropsychological programs. Montefiore has a neuropsychology department with graduate students who are being trained and postdocs. So you have a really good group of people, instructors and support there, that you may be able to get some extra information even for support and treatment afterwards. So I would call over to one of those 3 hospitals.
Thank you so much for that wealth of information. So again, I want to thank you, Dr. Sophia, for letting us learn some new things today. We had a lot of great feedback thanking you, and someone said it was worth taking their break a little longer to listen to you. So people did take time. Yeah, we all learned something new. And I want to thank everyone for joining us today. And again, I encourage everyone to join us again next week because we do have our special webinar. Oh boy, we have one more question. I'm sorry, there's a little technical difficulty on my end, so they're popping up a little later. I do apologize. Just one question: Are we receiving the PowerPoint presentation for reference? Just to let everyone know, all the handouts are on the right-hand side under handouts, and Dr. Sophia has her PowerPoint on the handout section. So if you click on it, you could download it to your desktop or wherever you see fit. So yes, everyone on the presentation can download this PowerPoint along with other handouts that we have. Again, that's on the right-hand side. So again, I want to thank everyone for joining us. Please continue joining us for all different topics and all different guest speakers. And I hope everyone has a wonderful rest of the afternoon. And thank you for joining us today. Have a good day, everyone.
Thank you.
Thank you so much.